speaker, Dr. Nicola Hanger from Italy.
Last speaker, so it's always a bit tough to keep attention. I thank the people who resisted up to now. I'll fly through. I mean, you've heard a lot of things during these days, and I think we are all aware of the problems that are out there. A bit different, a more aging population in richer states with maybe a much higher number of care facilities and carers. Younger population, but anyway, a trend towards an aging, a problem linked to aging of people. Also here in India, if you look at the demographic projections, as you were correctly saying, we are going forward to having a problem linked to the people that are aging and are becoming old. So we are well aware of this problem. We are well aware of the issues linked to high costs of health. In Europe, we have been talking also about social care, which is a problem. Elderly people who are isolated do become very expensive healthcare cases. And you will see, I guess, this development here as well. You know, the family, daughter, son will have to go to another city to work. The elderly parents will remain isolated. Maybe they will have some friends, they will still have members of the family, but it will become more and more difficult to be there the whole time, available to support them. So we have tried to work on a concept that we call the health center. Basically, the idea is, you have heard about patient portals, you have heard about patients at the center. We have tried to elaborate on these issues. And what we thought, basically, it would be nice to have a single point of access. You have health and social problem. You would like to find somebody who helps you to solve your problems. Problems can be linked to chronic diseases, so you need a real disease management program, like the one you have heard described. So you are a high intensity, high maintenance, let's use this bad word, patient. So sucking up a lot of resources, requiring a lot of attention, but you might just be a worried parent, first child, you know, baby is crying, oh God, what is going on? At 3 o'clock in the morning, grandma is not there to tell you that it's perfectly normal. You need some sort of support. Or you need to do your blood test once per year at least to see that everything is okay and so on. So you need help to organize this different way of accessing healthcare. Our idea has been to start with telephonic services and IT tools. So to make life as simple as possible, you pick up the phone and you ask for the services you're entitled to, or we pick up the phone and we remind you. We remind you that maybe you have to do a vaccination. We remind you that maybe you're over 50. It's time to start doing some more proactive testing. We are reminding you that you should measure your blood pressure because you have hypertension, you have comorbidities. So with this idea of organizing access, we basically have taken over a whole set of different activities that you can actually manage remotely. So where we started 20 years ago was with what are called social care and telecare. It's alarm system, basically designed for frail elderly people who are living alone. They can start, to press a button and get a 24/7 call center that answers immediately, listens to what is the issue and tries to find the correct answer. Maybe it's a problem with the apartment. It's not necessarily a health problem. Maybe it's a problem with an appliance that is not working. So supporting the elderly person to find the right answer. So moving from here, what we have introduced is a proactive preventative screening. So again, no money or little money available, even in richer European countries. We're coming from Italy, so still not high spending as Germany or France, and now will be even less spending in the next few years, I assume, as you might all know from television. So proactive, we call with a checklist. With a checklist and questions on social situation, on capability of surviving in your environment, so monitoring of activity of daily living and so on. And if you have diabetes, you have hypertension, on top of that, we check. We check if you are following a diet, we check if you are taking your pills, we check if you make a bit of movement. And we expanded from all this. So, from the alarm and proactive telephonic support, we started putting sensors at home to see if there were problems linked to gas, flood, temperature, and so on. We integrated the different social care providers and family and friends. So alert somebody there is a problem, so you can make an intervention. Do something. Make sure that somebody is answering. And starting from this part of the population, we then saw two other big problems. One was that part of this elderly population had chronic diseases and needed much more intensive monitoring. So you have heard about the wonderful things you can do today in terms of is there somebody who's organized? Is it a single doctor that has, I don't know, 4,000, 5,000 patients that is looking at the data that are coming in from 1,000 of this, so 20% might have a chronic situation. Maybe another 5% have done a major surgical or intervention or had an acute care episode, and so for like 30 days or 2 months or 6 months, they need much more intensive follow-up. So the idea is that we work together with the local healthcare provider. We do not want to enter between the person and the care provider. So the person must choose whoever is the correct doctor, the correct acute care facility, whoever they want to talk to. What we want is to make this interaction easy. And we introduce what we call a model of management by exception. So we agree with the doctor what is the protocol for the specific patients, what are the thresholds, what answer to a question is indicating that there is a problem, and we describe an escalation model. So there is something wrong with the patient. We can schedule an appointment with the doctor. We can organize a conference call with the doctor. If it's an emergency problem, and the doctor decides that it's an emergency problem, we then evidently try to go to to activate emergency services. So this is one part of the problem. The other part that everybody is correctly reminding us is that you would like to keep a patient well. Because this part of intervention is, the machine, the car has problems. So we have to start spending money to repair it. If we remember to change oil regularly, check the batteries, and do all these nice things, the car might go on working for a much longer time. So what we do for general population, we are present as information gateway. So you need information about where to find the pharmacy, what kind of different specialists are available in the area. We organize appointments for you. We remind you, are you in a risk population, need a vaccination? Do you need some preventative test? Because in the area there is some particular problem. So what we have is basically a call center with people that are skilled in managing different kind of care processes, but are not doctors. They don't do diagnosis. They agree with the care providers of the patient about what are the correct factors. We have software behind all this. So what we are doing is we are collecting the data from the patient. We are collecting this data together with the carer. We didn't do the step yet to allow the patient to set up the personal healthcare record. We had many discussions about this. We are looking forward to do it, but for us it was very important to have somebody together with the patient to check that the data that are input in the system are correct. This is not a minor issue. So you want at least to start with the patient where you're sure about what you're writing in the system, and then consequently what kind of processes you activate. We take care about integration. If there is anything else which is available out there. You know, you do your blood test, is there a laboratory information system? Let's make this data available electronically. You go to a cardiologist, consultant, you do ECG, you do something else. Let's have the reports at least available. So, call center, data integration, and we work on technology assessment. What kind of technologies can you give to the patient in order to make their life easier, in order to collect this data in a way to avoid error and to be effective? So just some numbers about what we're doing. I think it's important to look at the whole perimeter of services because you want to answer to the need of entire population groups. So from 5 million people that need active information on how to access healthcare and social care providers to the specific 5,000 that have a chronic condition or need post-discharge monitoring, so they need a period of very intensive monitoring. We have answers that are targeted in terms of price and solutions to all these people. So again, one telephone number, and in the future, one patient portal for all this. You have to think that I liked very much the slide that the previous speaker showed. Personal healthcare records. The big problem is how to make sure that all the data that is out there is available to the personal healthcare record, and the data you collect gets transmitted outside. It's not a minor issue. Times probably you could consider that in countries where there is less of an IT infrastructure, it would be easier, and I expect in India it should be easier to start with this kind of approach instead of Europe or the US, where there are a lot of legacy systems and a lot of distributed data around. It's fine? Good.
How much more time?
Well, I can be reasonably fast. I don't want to keep people here.
We will not have many people here.
Yeah.
You can't go anywhere.
I know.
You are my hostage. So I'm holding a couple of hostages, but no, I'm nice. Come on. I have to worry about my debt, which is big being Italian. Just to tell you, the average age of people we are following at home is 83. We do more than 2.5 million calls per year. We have alarms that are medical. Only a minor part of this alarm leads to hospitalization. We have more than 50 patients who are over 100 and are living happily at home. So this is the kind of results we want to achieve with our support. when we organize all access to primary care, again, we have a reduction in hospitalization. So what you do is basically, we organize all access to GPs, nursing services. What we see is that you get a reduction in hospitalization, a much higher compliance in screening, examination, and preventative actions, and you get a reduction in referral to acute care specialists. So this is money you save, this is clinical results that you get. And I mean, the best way to save money with all these things we are talking about is actually making patient better. You know, good clinical outcomes. That's the way you save money. It's, all the rest is a bit of poetry. Telemedicine, we are working with about 5,000 patients, and what we get, for example, diabetes, reduction in glycated hemoglobin, reduction in cholesterol, reduction in triglycerides, reduction in hypoglycemia events. So it's important to sit down with the specialist or the primary care doctor that is following the chronic patient and see what are the targets that you want to achieve. You want to preset the targets. You don't want the targets to be a surprise that you find out at the end. All this needs, as I said, web-based software. Our way to the future, and here I am, is that you will be able to deliver a whole set of different home-based services, which will be more and more based on the personal healthcare record. But you will have also tools to empower your patient, and I very much like what you said, 80% of the results are due to the patient and not to the professional. And as you were saying, with a webcam, you can put a video on the web, even if it's not high definition and so on, but explaining what happens, what are the best ways for doing physical activity. Remember, chronic condition, physical activity, diet, remember to take your pills. You don't need a cardiosurgeon for this. You need some common sense, good communication, and these things should be available to patients. We are looking forward to move this activity and this model from Italy, where we are now. We are now opening activities in the UK, and we are looking forward to move to India in the next months with this model. Thank you.
Thank you.
Can I ask a question?
Yep.
So, you mentioned that you have a protocol for each patient, when to call the primary care physician,
Yeah.
etc. Which means that for each person who signs up with your service, you will have to sit down with his or her physician and design that protocol. Isn't that time consuming for the doctor?
Yeah, of course you need to sit down with the doctor and agree with him, but there is no way out of this. I don't think that there is any feasible way of making a realistic disease management or care management plan without talking who is at the end responsible for prescribing, who knows the patient because he already talked, several times, and who can tell the patient, listen, you do not really need to come here, sit 3 hours, wait to talk with me 2 minutes. In this way, we are sure that as soon as there is some signal that you are getting out of control, the system will react. I will call you, and you will not need to self-decide when it's an emergency or a problem. So it's true. It takes time to the doctor for patient enrollment, but it's the only way to make this, at least in our opinion, to make this kind of program reliable.
When doctors realize the value, they must be recommending the service to their patients on their own.
Yes. Our experience, if you try to do this, we even try to work with, for example, a private hospital. Say we take the patient, we have the people in the private hospital, the specialists, and we do everything. People go to their doctor. They have a doctor, usually, everywhere, in all nations. You don't you don't go 1 week to one primary care and the following week to a different one. So either you work with the primary care doctor. Specialist, you can change the specialist. You need different specialists. You heard that there is a brand new cardiologist, Mark was studied at Harvard or whatever available somewhere. So you might want to try that one, but your GP stays there.
One more question. Do you get spurious calls? I mean, I imagine there are a lot of lonely senior citizens who just want to talk to someone. Do you get calls like that?
Yeah. We get spurious calls. We had, in this case, we get a contribution. So it's not only private payment, it's mostly public payment, because the citizens that are generating these calls, at the end, they, if you have a problem at midnight on Saturday, the only place that is open 24/7 is accident and emergency. So, your cat does not feel well, you end up in accident and emergency costing $1,500. Okay? So the idea is basically you can call us, we even find a veterinary for your cat, because we keep you safe at home. You are 83 years old, you want to feel safe. You pick up, you have a problem, eating is not working, it's too cold. Even in rich Europe, Sunday night, the only place you land, unless your son is coming and solving the problem for you, you go to accident emergency. They won't throw you out. You're 80 years old. Come on. Who's going to throw you in December out on the street with snow and everything? So you become suddenly that cost center that is making healthcare costs tremble and go up at double-digit growth rates.
Thank you.